I think I can see myself as well. So good evening, everyone. I'm Dr. Sandeep Sharma. I'm the Pediatric Faculty at DocTutorials for FMG. The exam is just around the corner, and so we will not be wasting any time. I know that time is precious for all of you. Now, before you ask me, hope everything is good. Vipin, everything is good. I'm in Kerala right now. I had a class at Trivandrum, and I was supposed to take a Vande Bharat Express from Trivandrum to Calicut. But the train was delayed by an hour. So I've just reached into my hotel room and immediately started with the session. So that is why the timings had to be adjusted a bit. But nonetheless, I will not take much of your time. What we are going to do is we are going to take up 20 MCQs. Why 20 MCQs? Because time is limited, but there are certain topics, certain questions which we as faculty feel you should have an idea. Are the same questions going to be asked in the exam? The answer is no. Then what is the purpose? These are the topics which are frequently asked. Some of these questions are very similar to recent INI set or NEET PG question, and you all know that these questions are being asked in FMG exam after modification as well. So we will be touching upon 20 questions I will be taking. I'll be telling why this is the answer, why this is not the answer, some additional points we will be writing, and we will be, summarizing the key points of that topic in a very rapid manner. At the same time, the 20 questions I've selected, at least 4 out of them are INI set MCQs. Now you would say, sir, why INI set? Because these are the peripheral questions which we generally do not teach in a traditional NEET PG or FMG class, but it does no harm. They are very much a part of pediatrics. So close to the exam, at least if you just listen to it, you will have that, 0.0001% extra confidence that, I have done those topics also, those things also, which my teacher has not taught me, but they are, and I said, trending topics. Okay. But remaining 16 questions, remaining 80% of our discussion will be related to FMG only. All the topics, none of these topics has, it is something which is a time wastage. So let us start without wasting any time. Uh, Let us start with the first question. A 9-year-old boy is short for his age but looks younger than his peers. Okay, so he's short for his age but looks younger than his peers. He is otherwise healthy and X-ray shows delayed bone age. What is the most likely cause? What is the correct answer? Many of you are answering it correctly. The answer to this question is B, constitutional delay in growth. Now, first of all, let us see why the other options are not the answer. Turner syndrome only occurs in ladies and they will have short stature along with webbed neck and facial dysmorphism. So D is ruled out. Okay. Look at A. A option is not the correct answer. Why? Because in familial short stature, the patient, the chronological age, the actual age of the patient is equal to bone age, right? So in these patients, the chronological age, that is the actual age of the patient is equal to the bone age. So this cannot be the answer because it is showing delayed bone age according to the age of the patient. So A is ruled out. What about growth hormone deficiency? Growth hormone deficiency will have severe short stature. They will have complications. They will have facial dysmorphism because question is saying he is otherwise fine. And there will be higher risk of other metabolic problems like hypoglycemia and all. I hope you know that growth hormone not only controls the height, it is also involved in the metabolism of the patient. So C is ruled out. So by ruling out the option also, you can reach the correct answer. Constitutional growth delay is your correct answer. PS girl, I have given the reason why I was late. The reason was simple. My train, Vande Bharat train, got delayed because flights are very risky these days because of the Indigo fiasco. So I was traveling through train, but even the train was a bit late. So I've just reached the hotel and I've just started. Now, what are the points that you should know? First thing for all the FMG aspirants, would a question be asked on short stature? We do not know. But should you be reading short stature in the last week before the exam? Yes. Whatever is your source, please read it from there. Some additional points I'm telling you, add these points to the notes if you do not know them. So short stature, what is the definition of short stature? Short stature is said to be there if any child is having height for age below third centile or height for age is below -2 standard deviation of the mean. Depending upon which chart you are using, you will have two types of uh, definitions. Height for age below third centile if you plot on a chart, or height for age below -2 standard deviation when you plot on a chart. That is the definition. Short stature can be of two types: physiological and pathological. Physiological, no cause is found, these are mild, and pathological, short stature is severe and there is a treatable cause. If the question says height or growth velocity is normal, always think of physiological short stature. If the question is saying height or growth velocity is reduced, always think of pathological short stature. Always think of pathological short stature. Thank you so much, Doc. Thank you so much. But because I want this session to remain crisp so that you people can listen to it again when it goes up on the YouTube. So and 1.5x you can revise it once again before the exam. So I will keep it short. So only relevant comments I will be taking up, and I hope you understand that time is running short for me and you, all of us. Any additional doubts you have, or any additional comments you have, you want to praise something, you want to criticize something, most welcome. But I will be sharing the details where you can reach out to me. For many of you are in touch with me already, but you can always reach out to me. But here, let us just finish off the 20 topics with full details the best we can. So height or growth velocity normal. What is height or growth velocity? Rate of gaining height. Physiological short stature, the overall rate of gaining height is normal. Just some event causes the short stature to develop, and it is a mild short stature. Height or growth velocity is reduced, and so these patients always have reduced short stature if it is pathological short stature. Then, if the MCQ says mild short stature, delayed puberty, delayed bone age, your answer will be constitutional delay in growth. Those of you who have sat in the exam, you would know that there was a similar question asked in the July paper of exam as well. And those who have seen the PYQs, there was a very similar question asked. Mild short stature, delayed puberty. How delayed puberty they will mention? They will not say directly. If they say, great. They will say that chronological age is 12 year, 13 year. Actual age is 12 year, 13 year. But testis size is normal. Puberty has not yet started. You know that when in boys, puberty begins. The testicular enlargement is the first feature. So they will indirectly hint that delayed puberty is present. And delayed bone age is lagging behind, which is actually, okay in these patients because patient will have a catch-up growth. So mild short stature, delayed puberty, delayed bone age compared to the actual age, constitutional delay in growth. If they say mild short stature, normal puberty, normal bone age, chronological age, bone age are equal, your answer will be familial short stature. Familial short stature. Familial short stature. Then what are the causes of proportionate short stature? अरे भाई, don't feel मैं मना नहीं कर रहा हूँ. You're most welcome to comment anything. I'm just saying that I will be taking up only the relevant comments, right? That is what I said. You're most welcome. It's a democratic country. You're free to post anything. So I'm just talking about myself. What is proportionate short stature? The body segment, upper segment, lower segment ratio remains normal. So in bracket, you would write upper segment to lower segment ratio is appropriate. These are proportionate short stature. Two varieties are there. Two varieties are there. It can be physiological also. It can be pathological also. So physiological causes of proportionate short stature, remember, constitutional delay in growth as well as familial short stature. Both of them are proportionate. Among the pathological causes, remember, growth hormone deficiency, protein energy malnutrition related short stature. I'm writing in short details. You can always, see from your notes or reach out to me later. And see, chronic illness related short stature will always be pathological. It will always be proportionate. What the meaning of proportionate is? The body proportion for that age. The upper segment, lower segment ratio for that age will always be within normal limits. We call it as proportionate short stature. What about disproportionate short stature? Disproportionate short stature is of two types. You have short limb dwarfism and you have short trunk dwarfism. Short limb dwarfism will always have a abnormally high upper segment to lower segment ratio. These patients will have abnormally low upper segment to lower segment ratio. The typical example of short limb dwarfism will be achondroplasia. It can also be seen in patients with osteogenesis imperfecta. It can be seen in patients with rickets and it can occur in patients with hypothyroidism. Whereas short trunk dwarfism typically occurs in vertebral disorders like spondyloepiphyseal dysplasia. There are other causes, but we are only summarizing the important ones. So again, on this particular thing, MCQ has been asked in the exam. Any update in pediatric theory for upcoming FMG exam? Yes, the update is National Neonatal Resuscitation Program, ninth edition has come. There is a summary of that I will be posting very shortly, not in this session, very shortly for all of you on the YouTube. You can just go through it. It will be a brief 5 to 10 minute summary. The changes in neonatal resuscitation, vast majority things are same. For now, continue reading whatever you are, whatever updates are there, I will summarize as a special video somewhere around Christmas time. It will be a Christmas gift from me to all of you. So this is your points related to short stature. Okay, look at this photograph. They will give a spotter like this. Very similar question is being asked in not FMG but other competitive exam. Look at this photograph, extra edge point. What can you see in this child? Can you see that this child is having a single central incisor? Normally we have two central incisors. There is a single central incisor. So I will label it. Any child who's found to have single central incisor or crowding of central incisors. Crowding means one central incisor jumping on top of the other. It will always indicate growth hormone deficiency. Always remember it is a marker of, it is not Hutchinson teeth, dear. Hutchinson teeth will have notches in that. See, this is the lips. My drawing is bad, but I will still try my best. If this kind of teeth are seen, these are Hutchinson teeth. If you find that there is a single large tooth in the center instead of two separate central incisor, that will indicate growth hormone deficiency. Once you have seen, you will never forget. So it's a one-liner thing. You can add to your notes and you can revise as well. Okay, topic is done. Question number 2. 4-week-old male infant presents with progressive projectile non-bilious vomiting after feeds. You already know male infant, first few months of life and non-bilious vomiting occurring after feed. He has signs of dehydration and there are complications like hypochloremic, hypokalemic metabolic alkalosis, and ultrasound photograph has been shown. In this ultrasound photograph, although it will not be shown to you, it will just be of, so-called shock value for you, but you can see there is a dilated proximal stomach and the outlet of the stomach is becoming narrow. This is the lumen which has become narrow. Can you see this black thing which is in the center? That is the lumen and it is producing a sign what you call as the antral nipple sign. So remember, ultrasonography in these patients shows a sign known as antral nipple sign. Antral nipple sign was asked in NEET PG exam some years back. So you have a presentation like this. The likely diagnosis in the patient is CHPS, also called as IHPS. Congenital hypertrophic pyloric stenosis or idiopathic hypertrophic pyloric stenosis. Whenever you make the diagnosis, what is the first step in management? Always start IV fluids. Once you have managed the hypochloremia, hypokalemia, alkalosis, then you go for surgery. And the name of the surgery in these patients is Ramsted's pyloromyotomy. Immediate pyloromyotomy is never done. It is never done. It is all surgery is always the second step in the management of these patients. Now look at the option. What is the correct answer? The correct answer in this question is start IV fluids to correct the electrolytes first. So you have to make the diagnosis and you have to know the management part. Approach. Why did I put this question? Simple thing. I wanted to discuss a brief differential diagnosis with you. Examiner will put question. Vomiting occurring in infant. How you are going to approach? First thing, if the examiner says non-projectile, non-projectile, passive vomiting. Passive vomiting is the word, a non-projectile passive vomiting word they will use. That you will always think of possibility of gastroesophageal reflux disease in the infant. Gastroesophageal reflux disease in the infant. If you're scoring less in the mock exam, please reach out to me. Next couple of days, I will try my best. I'm taking classes, but I will be available after 9:30 or 10 for half an hour, 40 minutes. Any doubts, please reach out to me through the through the Instagram or through the Telegram group. I will share the links also with all of you. So non-projectile passive vomiting, GERD should be thought of. GERD means reflux, gastroesophageal reflux disease. If the examiner says projectile vomiting is occurring in an infant, projectile vomiting always indicates obstruction in the patient or raised intracranial pressure. But raised ICP will not be considered because it is an infant. In a infant, the anterior fontanelle is open, so our only cause of projectile vomiting will be obstruction. From exam perspective, right? We are not talking about rare causes, we are talking about common causes. If they say projectile vomiting and they write non-bilious vomiting, projectile non-bilious vomiting, your diagnosis will be CHPS or IHPS. If they say patient is having bilious vomiting and there is abdominal, but there is no abdominal distension, no abdominal distension, your answer will be duodenal atresia. Your answer will be duodenal atresia. And if they say bilious vomiting with abdominal distension, then your answer in the question will be jejunal or ileal atresia. Jejunal or ileal atresia. Remember, if it is GERD, you have to do endoscopy and biopsy, which is the investigation of choice. In all the other three conditions, the investigation of choice is ultrasound, but if you do X-ray, what you will find? Here you will find single bubble appearance. Here you will find double bubble appearance. Here you will find, if it is jejunal atresia, you will find triple bubble appearance. Triple bubble has been asked in FMG exam 2023 July exam already. And if it is ileal atresia, it will show multiple air fluid levels. Multiple air fluid levels. Remember, in all the three conditions, the investigation of choice will still be ultrasonography, right? So at least the diagnosis should not go wrong if the examiner either makes a case scenario or he mentions as a one-liner or he mentions 2 or 3 points or gives an X-ray. This is the differential diagnosis. All the four in different exams have already been asked. So it is not just it's a simple flowchart, but it is covering at least 4 PYQs across platforms, across your exam platforms like NEET PG, FMG, and INI. Let's go to question number three. Let's go to question number three. For those who are where can we get this PDF? The PDF rights are with DocTutorials because I'm taking on their channel. So, but this video will be available to you. This video will be available to you. So please try to, you can see this video again, but the rights are with DocTutorials. I hope you all understand. Third, question number three. Question number three. And in case you have any doubts, you are most welcome to reach out to me. You can reach out to me through my YouTube channel. You can scan and join on Instagram. There is the Telegram link also available. I'm there on X, Twitter, but stay away from Twitter till you crack your exam. And there is a pediatrics channel for MCQ discussion also, which is there. So this particular thing I will put up after I end the session also. You're most welcome to scan it and you can join me, and any queries you have, you can post about this topic. But the file directly I cannot share with you, all of you. Let us start. A preterm infant with suspected NEC. A preterm infant with suspected necrotizing enterocolitis shows pneumatosis intestinalis on X-ray. The abdomen is soft and non-tender. What is the appropriate next step? Now, you have to look at NEC. What is NEC? Necrotizing enterocolitis. It is an inflammation of the gut seen in preterm newborn. What this question is saying is NEC is present and there is pneumatosis intestinalis. If you have done the Bell staging tells you that presence of pneumatosis intestinalis indicates stage 2A of NEC. Whenever you have portal vein gas, then it is stage 2B. And if perforation peritonitis occurs, that is stage 3. So this patient is having stage 2. In stage 2, conservative therapy is needed. Whenever you are doing conservative therapy, you have to make the patient NPO, nil per oral, give IV fluids, give antibiotics, and manage any complication if it is happening. So now look at the option. Would you continue feed in NEC? No. Is there any role of steroids? Steroids can only prevent NEC. There is no role on treatment. So D is not the answer. Would you do immediate laparotomy? No. Immediate laparotomy is needed in stage 3, where there is perforation or peritonitis. Stop feed and start broad spectrum antibiotic is your correct answer. Remember the funda. Whenever there is a preterm child presenting to you with abdominal distension or bleeding per rectum, always suspect NEC. Always suspect NEC. If you are suspecting NEC and you find that there is pneumatosis intestinalis, that will indicate stage 2A. If you find portal vein gas, that will indicate stage 2B. If you find ascites, that will be stage 3A. And if there is perforation, that will be stage 3B. These will be the clues in the MCQ. Remember that whenever you have stage 2A and 2B, only conservative therapy is needed. Only conservative management is needed. But whenever you have stage 3A and 3B, surgery, that is laparotomy, will be needed in the patient. Surgery or laparotomy will be needed in the patient. Okay. And many people keep saying, sir, how does pneumatosis intestinalis look like? Are they going to ask? I'm quite sure they are not going to ask. But if they ask, you're having a bad day. If you have seen, you will never forget. So as I said, I will be just pushing the boundary a bit on the same topics. This is a typical X-ray. If I am an examiner and I have to put a non-copyrighted image and a very characteristic image of NEC, I would be putting this photograph. Why? You will see that there is abdominal distension. You will see that there is, dilated bowel loops. But most importantly, what is pneumatosis intestinalis? Air bubbles in the wall of small intestine. In my class also I teach you air bubbles in the wall of small intestine. If wall में आएगा, तो it will form a black color because air appears black on X-ray. It will form a circumferential black color thing in the wall. Look at this particular thing. Can you see that in the center you have this particular part which is the lumen filled with air? And can you see air is also present as a circumferential black ring around it? Right? So this particular thing which is present on the outside is air bubble in the air present in the wall of small intestine. So this much of photo is sufficient for me to tell this is necrotizing enterocolitis stage 2A. Once you have seen, you will never forget. Perforation and peritonitis are perforation, football sign and air under the diaphragm, gas under the diaphragm, they are easy to identify. And I'm quite sure you have seen already in radiology classes, but this is the typical photograph of pneumatosis intestinalis. Keep this, frame this in your mind. You never know. Let's go further. Question number 4. Question number 4. A 2-year-old child is brought to the clinic and presents as shown in the image below. The mother says the child was weaned early and now eats mainly diluted rice porridge. Based on the maladaptive hypothesis, what is the underlying cause causing this child's edema and fatty liver? Now, what are the clues in the question? Child's edema. Edema is present. Fatty liver. Fatty liver is present. And diluted rice porridge, weaned early weaning present from the breast milk, which is a trigger factor. Everything pointing towards what diagnosis? Yes, absolutely right. I'm very happy. Kushal Pandya, Karish dot Mota Mang. What is this name? Prem Kishore, everyone is getting it right. Absolutely right. It occurs due to protein deficiency. So what will happen in these patients? These patients will have hypoalbuminemia. They will not only have external protein deficiency, their internal protein, because amino acids are not coming, so they will have difficulty to form internal proteins as well. And because there is poor lipoprotein formation, fatty liver occurs. Why fatty liver occurs? Because liver forms lipoprotein. उसमें दो component है, lipid and protein. Lipid is still the liver can make, but protein is not there. So all the lipoprotein formation gets affected. It causes accumulation of fats in the liver, right? देखो, try to understand like this. Liver forms lipoprotein. Okay. For lipoprotein, you require lipid and you require protein. It is malnutrition. Lipid upregulation, liver can still do, but protein is severely deficient. So what will happen to the lipids? These lipids will stay back in the liver and unnecessarily they will cause fatty liver. It is much more complex than this, but you can remember like this. And so what is the correct answer among the options given? B is your correct answer. B is your correct answer. So thank you, Arvind. All 20 questions I have done, Dr. I have out of 20, I have attempted 16 correct. Great. 16 is a very good score because, as I said, four questions are INI set. Probably you got the INI set questions wrong. It's okay. At least you are pushing the boundaries. Awesome. Awesome. Let's continue. These MIQ tests will be done on the DocTutorials app. So, dear students, whatever tests are made available to you, make sure to keep doing it. We are discussing them, and these are very high quality tests created by the faculty only, right? It is not some AI making or some third party making them. So we have, mixed it up and edited them ourselves. Next question, question number 5. 4-year-old boy has difficulty rising from the floor, uses his hands to push on his thighs to stand and has calf hypertrophy. Difficulty rising from floor using his hand to push on the thighs to stand. This is called as Gower sign. Child climbs upon his own body and he has calf hypertrophy, which is actually not true. So calf pseudo hypertrophy is there, and 4-year-old boy, male child, everything pointing towards a diagnosis of Duchenne's muscular dystrophy. Duchenne muscular dystrophy. So B is your correct answer. Absolutely right. Identify this. Tomorrow they may show photograph. Which sign is being done? This is Gower sign which is being done. Right? They can show photograph, ask you which sign is being done. Sitting or lying down child first gets into prone position, forms a triangle, then climbs upon his own body. This actually is called as Gower sign. Those who will be preparing for PG entrance tomorrow, we will discuss in details. And we will definitely discuss in details. At this moment, a bit of positivity is needed. Yes, you should be pushing yourself, but manifest that you are going to crack the exam. And after the party season is over, after the results are over, the party season is over, we have to meet again. You and me, we have to meet again for PG entrance exam. So with that, at that time, we will talk about more details of this. For now, just remember this is Gower sign. This is calf pseudohypertrophy. Calf muscles look like muscles of a footballer. By the way, Messi was in India. So next time he's in India, you might be going to meet him. Right now that there is no time for all of us because exam is looming around. So Gower sign is positive along with this. So DMD is your answer. Also remember that Gower sign can be positive in Duchenne muscular dystrophy. It can be positive in dermatomyositis, and it can be positive in Pompe's disease. I hope you know Pompe's disease, glycogen disease type 2. Remember, originally, Gower sign was described for Duchenne muscular dystrophy. If examiner says Duchenne muscular dystrophy is ruled out, which other condition can have this? Dermatomyositis can also have it, and Pompe's disease can also have it. Okay, let's go further. Question number 6. Now, this is a tough one. This is a INI set style question. 2-month-old infant with persistent tachypnea, poor feeding, failure to thrive. Oxygen saturation remains low despite supplemental oxygen. HRCT test shows diffuse ground glass opacity and bronchoalveolar lavage yields milky proteinaceous fluid. And there is a history of similar deaths in the family, in the sibling. What is the most appropriate management? Now you need to understand. Let us write down. Let us try to understand what is happening here. Whenever a newborn presents, whenever a neonate presents, whenever a neonate presents with oxygen, whenever a newborn presents with respiratory distress, unresponsive to, unresponsive to oxygen, respiratory distress, unresponsive to oxygen, you should suspect two things. Either it is a RDS patient or it is a surfactant deficiency patient. Surfactant, surfactant disorder patient. What is surfactant disorder? RDS is surfactant deficiency. This is more common and it is seen in preterm neonates. Its management is something you already know. What are surfactant disorders? Many patients have genetic defects in which there is deficiency of SPB protein in the surfactant. There is deficiency of SPB protein in the surfactant. In these patients, whenever you will do HRCT of the chest, you will find ground glass opacities. So X-ray features similar to RDS can be seen. And there will be, whenever you do lavage of the lungs, you will find milky fluid present in the airways. Milky fluid present in the airways. These are surfactant disorder. And in these patients, the treatment of choice will always be repeated lung lavage. Lavage means repeated cleaning of the lung will be needed. Eventually, lung transplant will be needed in the patient. Eventually, lung transplant will be needed in the patient. Now, look at this question. There is poor response to oxygen. HRCT is showing deficiency of SPB. HRCT is showing diffuse ground glass opacity, and lavage is showing milky proteinaceous fluid, and there is family history in the patient. All these patients are autosomal recessive in nature, autosomal recessive inheritance. So the answer to this question is B, whole lung lavage. Why are we discussing this question? Because similar question has been asked in INI set exam. If we sit in the exam without knowing anything about the topic, it's dangerous. But if you are preparing well, there is no harm in remembering the keywords. How much time it will take? You listen to it first time, just have a look at it second time. If a similar thing does get asked in the exam, there is no harm in this. So this was a tough question. The reason for putting it is two. Number one, INI said style question is there. Similar question topic has been asked and it is not discussed in, I'm quite sure any of the pediatric FMG educators, all of them are great. None of them, discuss this because, it is not a traditional FMG topic. Second, when you sit in the exam, it will never happen that in one subject, you know all the questions. It is okay to have one or two questions which are bouncers and going above your head. That is what will happen in actual exam also. So when we made these 20 questions, we made sure a couple of bouncers, but these are useful bouncers, are there in which you can just make an intelligent guess. So answer to this question is B, that is whole lung lavage. Bronchopulmonary dysplasia is a you can say complication. It is a sequela of RDS, but it is not bronchopulmonary dysplasia. Bronchopulmonary dysplasia is dependence on oxygen because someone is saying so bronchopulmonary dysplasia ये chronic lung disease होती है. This is a chronic lung disease of the newborn and here the patient is oxygen dependent, not unresponsive to oxygen. It is a sequela. Sequela means delayed complication of RDS survivors. Those children who survive RDS, they tend to develop bronchopulmonary dysplasia. Okay, let's go further. Question number 7. And what is the name of this condition, by the way? This condition is also called as neonatal PAP. Please remember the name is neonatal PAP. What is PAP? Pulmonary alveolar proteinosis. That is the name used for this condition. Although these days we prefer using directly SPB protein deficiency, but this is the older name. Neonatal PAP is the other name of this surfactant disorder that we are talking about. Let's go to question number 7. Question number 7. In question number 7, look at these key points. 2-day-old healthy term neonate developed multiple erythematous macule and papule with small yellow-white lesions that are central pustules on the trunk and face. Palms and soles are normal, no symptom, no fever, nothing in the child. What is the likely diagnosis? Remember, if there is a skin lesion in a newborn is otherwise asymptomatic, it is generally a benign condition in a newborn. And all of them, because it is day 2, a rash which is erythematous with yellow-white lesion occurring on trunk and face, asymptomatic child, it is erythema toxicum neonatorum. It is not miliaria rubra. Neonatal herpes infection will have a sick child and they will have vesicles. Herpes causes fluid-filled lesion, vesicle. So this is ruled out. Miliaria rubra is due to sweat gland blockage. Newborns do not sweat in the first week of life. They occur in older children. And these patients, rubra means red. Miliaria rubra is also known as Gamoria. I hope you know Gamoria. चुभती जलती गर्मी का सीजन आया, that advertisement which you have seen, that is miliaria rubra. It does not occur in newborn, and this will occur in intertriginous areas. Intertriginous means skin folds, it will occur, not on the face. So this is also ruled out. What about impetigo? It's a streptococcal infection. These patients will have honey crust, and they will be sick child. So this is also ruled out. Either you can rule out the option, reach the correct answer, or directly reach the correct answer. This is B, erythema toxicum neonatorum. Many of you have got it right. I hope you remember the funda. Whenever there is a newborn, listen to me carefully, I'm not writing. Newborn in the first week of life, he is asymptomatic, afebrile, and no other problem. It is a benign skin lesion. If there are lesions in the nose and cheek, that is due to sebaceous hyperplasia. If rash appears on the trunk and face on second day and disappears in 1 week, किस तरह का rash? Erythematous, red colored rash with yellow white pustule like lesions, and only on the trunk, never involves palms and soles, and goes away within 1 week. And if you try to do skin scraping or biopsy, you find eosinophil. This is the diagnosis, erythema toxicum neonatorum. If you find black macules, purple macules, blue macules on the buttocks, that is Mongolian spot. And fourth, somebody was asking me, ki, sir, any update? Yes, update is there. Write down. Mongolian spot का नया नाम है. These days, Mongolian spots are being called as dermal melanocytosis of infancy. Please add it to your notes. It should not happen that they put it in the question and you keep thinking कि सर ने तो पढ़ाया नहीं. This is the other name. So somebody was saying सर update है, ये है, छोटा सा एक update है, just add कर लो. था पहले भी, but it is now, being used more and more in some of the other pediatric books apart from Ghai and Nelson. They have removed the word Mongolian spot, right? So dermal melanocytosis of infancy ये होगा. और अगर half body dark, half body red है, yellow, white है, so then you will think of harlequin color change. And finally, if there is a hyperpigmented patch with pustules on it, then it is neonatal pustular melanosis. ये 5 conditions हैं you have to watch out for. I have discussed in my detailed classes. Please go through them from your notes as well. Okay, let's go to the next thing. Question number 8. Easy one. It's doable. 15-year-old adolescent presents with recurrent brief jerky movements of both upper limb. दोनों हाथों में झटका आता है. Within 1 hour of waking, more in the morning hours, and there is a falling of objects from the hand. She also has GTCS. Other type of seizures can also occur. What is the EEG? EEG they have given. Let me tell you, if they give you EEG, you cannot identify. So it will just be, to take, to have some fun with you. Most of the EEGs at FMG level, you cannot. I'll say NEET PG level also, people cannot identify, right? People do show them. Let me tell you, don't waste your energy. ECG, still doable. EEG, don't waste your energy. Once you take up medicine or pediatrics, all life you have to read about EEG. Psychiatry also, you will all life you have to read. If you're going to be an orthopedician or a simple medical officer, what's the point, right? So do thing which is doable, which is high yielding. So अगर फिर भी देखना हो तो इसके अंदर हमें दिख क्या रहा है? In this is 1 second. Basically, this is 1 second. And in 1 second, I can see these waves. Let me show कि wave कैसा होता है. पॉली स्पाइक किसको कहते हैं? एक स्पाइक आया, फिर एक और स्पाइक आ गया, फिर स्पाइक आ गया, फिर एक छोटी सी स्लो वेव आती है, फिर देन स्पाइक 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 एंड देन स्लो वेव. कैन यू सी दिस? This pattern is called as poly spike and slow wave pattern. Now, what is the clue we have? Dropping of objects more in the morning, bilateral jerks are happening, other type of seizure can occur, and poly spike and slow wave. What is the likely diagnosis? This is juvenile myoclonic epilepsy. Remember the funda. कैसे डिफरेंशिएट करेंगे? बहुत सिंपल है. देखो मैं एक डीडी बनाता हूं so that you don't get it wrong. If examiner says age less than 2 year plus jerks of the hands and feet, salam spell कहते हैं उसे. These are infantile spasm with neuroregression or developmental delay, along with EEG showing hypsarrhythmia. EEG showing hypsarrhythmia. Then the diagnosis will be West syndrome. And in West syndrome, what is the drug of choice? ACTH followed by vigabatrin. Exception क्या है? If it is a patient with tuberous sclerosis, then you will prefer vigabatrin over ACTH. Right? EEG में हिप्स अरिथमिया कैसा दिखेगा? देखो हिप्स अरिथमिया ऐसा दिखेगा. All waves merging into each other. कुछ समझ नहीं आएगा. That is hips arrhythmia. If the examiner says age, any age, in fact, any age, but generally younger children, 3 to 10 year, with vacant staring look, और साथ में होगा 3 हर्ट्स. पॉलीस्पाइक वर्ड नहीं होगा, स्पाइक एंड स्लो वेव. इसमें एक ही स्पाइक होता है. देखो एक स्पाइक आएगा, फिर एक स्लो वेव आ जाएगी. एक ही स्पाइक आएगा, डबल स्पाइक नहीं होते. तो लाइकली डायग्नोसिस रहता है इन पेशेंट्स के अंदर absent seizure. Details you already know. And if examiner says any age 12 to 18 years with dropping of objects from the hands because of jerks, we call them as myoclonic jerks, which occur in the hands, plus 4 to 6 hertz polyspike and slow wave pattern, then your answer will be juvenile myoclonic epilepsy. I hope now you will not get it right. मैं इसीलिए कह रहा हूँ कुशल, डोंट गो इनटू द डिटेल्स. ये फाइनल नुएंसेस होते हैं. रीडिंग अ ईजी, रीडिंग अ सीटी और एमआरआई, रीडिंग दिस ECGs even I would say, they are all acquired skills. So you need time for that. When you have 19 subjects to do, so don't waste unnecessary energy. A smart student is the one who understands his or her, limitation and doesn't try to do everything. If you try to do everything, you remember nothing. So things which are more frequently asked, because it's a licensing exam, you are not supposed to do better than others. You do better than others, great. But the most important thing is doing enough so that you cross the line. So close to the exam, don't read rare things and don't fall prey to. And as exams will come, you will have more, fancy things coming your way. Let us finish medicine in 30 minutes. Nobody can finish medicine in 30 minutes. So these are clickbait videos. Every year they come. So don't waste your energy on those, right? So you want to, just for the fun sake, then it is a separate thing. So question number 8, the answer is B, juvenile myoclonic epilepsy. लो मैंने zoom out कर दिया. I hope you can see the screen now. Okay. Sir, end of one page side is not visible. लो मैंने zoom out कर दिया zoom out भाई. देख लो आराम से देख लो, कुछ नहीं है, कुछ मिस नहीं हुआ है आपका. मैंने zoom out कर दिया. You can see it now. I've zoomed up. Okay. What about option C? Lennox-Gastaut syndrome. Great. Lennox-Gastaut syndrome, age 2 to 6 year, severe seizures, neuroregression, and they will have atypical absent seizure plus GTCS, mixture of both. This is not fitting there. This is what you have to watch out. Okay. Let's go further. Let's go further. Question number 9. Previously unvaccinated 7-year-old boy presents for routine immunization. The mother says he has received no vaccine since birth. He is healthy, has no contraindication, etc. etc. अब 7 year पे आया है. Which vaccine should not be given to this child at his current age? Question like this looks tough, but they are just wasting your time by giving unnecessary information. 7-year-old boy, he unvaccinated. Which vaccine will not be given? Hepatitis B can be given. It can be given. IPV can be given, can be and should be given. DTP containing vaccine, obviously. What about rotavirus? Rotavirus vaccine is not given after 1 year of age. Yes, Kushal Pandya, but I have not mentioned spike and slow wave because you will not be able to identify 2.5 hertz. That is why I have not written there. So rotavirus vaccine not given after 1 year, Ajay, and that is the answer. Remember, three vaccines are not given if they you miss them: BCG, DPT, BCG, pentavalent, and rotavirus. DPT can be given, right? Question number 10. Look at this. This is an easy one, very similar to an actual question asked in your FMG exam. What is the answer? 4-year-old boy, low-grade fever, painful mouth ulcers, rash on hands and feet. Preschool teacher reports multiple children with similar symptom. Based on the clinical picture and the image provided, what is the likely diagnosis? Rash on hands, rash on feet, ulcers, not only in the oral cavity, but around the lips as well. This is hand, foot, mouth disease. This is hand, foot, mouth disease. Why are you thinking of erythema multiforme? It is hand, foot, mouth disease. It is mostly caused by Coxsackie virus. Which Coxsackie? Coxsackie A16, followed by enterovirus A71, followed by enterovirus A71. Treatment is supportive. Okay, treatment is supportive. Let's go on. It's an easy one. Question number 11. Newborn is delivered with the abdominal wall defect shown in the image. What is the likely diagnosis? If I zoom in, you try to see the defect is not coming from the umbilicus. It is coming from the side of the umbilicus. From here, the herniation is happening and there is no sac and intestines are matted and they have a matted look and they are hanging outside the body. So this is what you call as gastroschisis. Gastroschisis. Your answer to this question is gastroschisis. जब भी sac बनेगा तो omphalocele है. They are hanging outside, gastroschisis. Umbilical hernia में only the umbilicus will balloon out, but nothing will be herniating outside the body. Bladder extrophy, very easy to identify. You will have midline below the umbilicus. You will have the patient having raw area of anterior of the bladder wall protruding outside. So answer is gastroschisis. Look at these two pictures. It's a very important table. You can go through it. Gastroschisis looks something like this. And when there is a well-defined membrane present of amnion and peritoneum, we call it as omphalocele. In these patients, I am highlighting these words. Highlighting these words. Covering membrane is absent. Covering membrane is present. Here, bowel matting and intestinal atresia is there. Here, pulmonary hypoplasia and congenital heart disease is there. Remember, if you can't remember anything, just remember how they look like and these 2 points. If you just remember these 2 points, you are good to go. This video will go up on the YouTube. It is there. You can always take a, stop, write down the points if you don't know any of them, and they are important. Let's go further. This is, now what is this? This is what is called as bladder extrophy. Bladder extrophy, also called as ectopia vesicae. One of the option was bladder extrophy, ना तो ये है वो. कैसे आइडेंटिफाई करेंगे? सी, ये अम्बिलिकस है तो अम्बिलिकस के नीचे है. ओम्फैलोसील गैस्ट्रोसाइसिस इसके साइड से होता है या इसी एरिया से होता है? दिस इज बिलो दिस. एंड कैन यू सी द प्यूबिक रेमाई आर आल्सो सेपरेटेड. So this is ectopia vesicae. This is ectopia vesicae or bladder extrophy. Remember, these patients have high risk of developing adenocarcinoma of the urinary bladder. They have high risk of developing adenocarcinoma of urinary bladder. Okay, just a spotter image. If this is a ionized image, ionized image. That is why I have kept it in the discussion part. Ionized image, by the way. Just that photo दिखाया बोला diagnosis बताओ. Let's go to question number 12. Match the congenital cardiac lesion with the most typical clinical finding. Look at these options and tell me the answer. Easy है. सबसे पहले continuous machinery. देखो, people what they do is they look at the column 1, then they go to column 2. In some questions, actually the reverse is easier. So continuous machinery murmur किस में होता है? PDA में होता है. So सबसे पहले 3 के साथ A है. So 3 is with A. दूसरा, अब इसमें से साइनोसिस कौन सी है? साइनोसिस वाले दो हैं, TOF एंड TGA. लेकिन साइनोसिस इन न्यूबॉर्न विद माइल्ड साउंडिंग मर्मर एंड सिंगल S2, ये जाएगा, बी जाएगा TGA के साथ, यानी कि 4 पे. फिर आया TOF. TOF विल हैव टेट स्पेल, द टिपिकल टेट स्पेल अलोंग विद पल्मनरी इजेक्शन सिस्टोलिक मर्मर. सो 1 के साथ जाएगा आपका D. और टू के साथ क्या जाएगा? होलोसिस्टोलिक मर्मर, ऑल्सो कॉल्ड एज पैन सिस्टोलिक मर्मर एट द लोअर लेफ्ट सर्नल बॉर्डर. सो 2 के साथ आएगा आपका क्या बचा? सी. So now look at the options and tell me the answer. 1D, 2C, 3A, 4B. A is your correct answer. A is your correct answer. मुश्किल नहीं है. You just need to watch out for the keywords. Now, for those who are interested, if you are interested, I am interested. If I am interested, you should be interested as well. Congenital heart disease में diagnosis गलत नहीं होना चाहिए. तो क्या चीजें याद रखनी है? Let us summarize them. I'll just take 2 minutes, but let us summarize them. अगर एग्जामिनर बोले, that is why I'm writing it here. If examiner says asymptomatic patient or mild CCF, asymptomatic or mild CCF, no shunt murmur, wide fixed splitting of second heart sound, wide fixed splitting of second heart sound. तो likely diagnosis will be ASD. ASD के अंदर if you find the ECG is showing right axis deviation, so your answer will be ostium secundum ASD, which is the most common variety. And ECG showing left axis deviation. I'm writing fast, but every point I'm writing is important from exam perspective and revision perspective. So इसे कहते हैं ostium primum ASD. So please ignore the writing because I have to write very fast and cover maximum ground. Second thing, if the examiner says congestive cardiac failure, pneumonia, feeding issues, feeding difficulty, particularly sweating on forehead while feeding. बच्चा दूध पीता है तो उसका सांस फूलता है. Feeding issues and pansystolic murmur, also called as holosystolic murmur. Although pansystolic is the preferred term, holosystolic murmur on the left sternal border, likely diagnosis is VSD patient. VSD patient. Okay. तीसरा, if examiner says VSD like presentation, but neonate or young infant having CCF and you have continuous machinery murmur, your likely diagnosis will be PDA. PDA में क्या देते हैं? Ibuprofen or indomethacin. But if you have to choose one, ibuprofen should always be preferred. चौथा चीज, if examiner says hypertension in upper limb, low BP in lower limbs, radiofemoral delay, late ejection systolic murmur, and figure of 3 sign, ये सारे clues है on chest X-ray. The likely diagnosis will be coarctation of aorta. Which is the most common type? Most common is juxtaductal variety. If it is not in the option, second common is postductal coarctation. Preductal बहुत rare होता है. Preductal is very very rare. Surgery करना है especially. Next scenario, if examiner says साइनोसिस प्रेजेंट इन द पेशेंट. अब साइनोसिस वाली तो बहुत सारी डिजीज हैं, कैसे पता चलेगा? साइनोसिस है एज इक्वल टू और मोर देन 2 months, 2 महीने के बाद भी सरवाइव करेगा. स्क्वेटिंग हिस्ट्री इज देयर, बच्चा स्क्वेटिंग में बैठना पसंद करता है और पुटिंग और मदर प्रेफर्स पुटिंग द चाइल्ड इन नी चेस्ट पोजीशन. ये क्लूज को देखना है. देयर इज अ murmur, ejection systolic murmur in the pulmonary area, ejection systolic murmur in the pulmonary area, and there are tet spells also called as cyanotic spells. बार बार वर्सन होता है पेशेंट. X-ray showing boot shaped heart, Coeur and Sabot. Now you know the answer. It is TOF, tetralogy of Fallot. इसके कंपोनेंट गलत नहीं करने हैं. कंपोनेंट आता है बार बार, उसके बाद भी लोग गलत करते हैं. I personally know many students who are now interns and post intern, लेकिन जब उन्होंने एग्जाम में आया क्वेश्चन गलत किया. क्यों गलत किया? पास हो गए लेकिन फिर भी दैट नहीं करना है. There's few things which should not be done. So TOF, right? नेक्स्ट अगर बोले साइनोसिस है एंड नियोनेट है साथ, एंड नियोनेट हैज, now look at the keywords, neonate having cyanosis with single S2, murmur plus minus, murmur plus minus, parallel circulation, तो आपका डायग्नोसिस होगा टीजीए। वॉच फॉर द कीवर्ड्स, ये मिस होता है हमसे। मैंने क्या बोला था, आई विल बी कवरिंग some points which are ionized related but topics are the same for FMG, right? तो उसमें थोड़ा सा 0.505% मैं बाउंड्री पुश कर रहा हूँ, यू नेवर नो। सो टीजीए पढ़ा है आपने इनके बारे में, एमसीक्यूज भी है इनके, so you might have faced some difficulty also in solving during QBank when you get mixed questions. So TGA के अंदर हमें क्या मिलता है, egg on string appearance also called as egg on side appearance also called as egg shaped heart, egg shaped heart। तीसरा अगर एग्जामिनर बोले नियोनेट हैविंग साइनोसिस है, साइनोसिस विद वाइड फिक्स स्प्लिटिंग ऑफ सेकंड हार्ट साउंड, साइनोसिस विद वाइड फिक्स, मेरा आईपैड मुझे बोल रहा है कि सोने का टाइम हो गया, वाइड फिक्स स्प्लिटिंग ऑफ सेकंड हार्ट साउंड, तो साइनोसिस विद वाइड फिक्स स्प्लिटिंग ऑफ, और मेरा इंटरनेट ऑन है, कोई नोटिफिकेशन आए मूवी वगैरह का या कोई मैसेज आए तो इग्नोर करना है उसको, राइट? सो साइनोसिस विद वाइड फिक्स स्प्लिटिंग ऑफ सेकंड हार्ट साउंड अलोंग विद सेम SpO2 in all four chambers, तो लाइकली डायग्नोसिस होगा TAPVC, वॉच इट आउट, TAPVC। TAPVC में एक्सरे में क्या दिखता है, दिस इज समथिंग यू नो ऑलरेडी, स्नोमैन और फिगर ऑफ एट अपीयरेंस और कॉटेज ऑफ अपीयरेंस, और इसका मोस्ट कॉमन टाइप क्या होता है, सुप्राकार्डियक TAPVC, सुप्राकार्डियक TAPVC। फिर एग्जामिनर बोलेगा नियोनेट हैविंग साइनोसिस with left ventricle hypertrophy or left axis deviation on ECG। सभी साइनोटिक डिजीज में राइट वेंट्रिकल बड़ा होता है, रिमेंबर आई रिपीट, ऑल साइनोटिक डिजीजेस हैव राइट वेंट्रिकल एनलार्जमेंट, ओनली वन डिजीज हैज लेफ्ट वेंट्रिकल एनलार्जमेंट, लेफ्ट एक्सिस डेविएशन, सब कुछ लेफ्ट साइड की तरफ चलता है, दैट इज ट्राइकस्पिड एट्रिशिया, ट्राइकस्पिड एट्रिशिया, ट्राइकस्पिड एट्रिशिया। एंड लास्टली अगर एग्जामिनर बोले नियोनेट, आई होप यू कैन सी, मैं थोड़ा जूम आउट कर रहा हूं, नियोनेट हैविंग साइनोसिस विद मैसिव आरए एनलार्जमेंट, मैसिव आरए एनलार्जमेंट प्लस प्रेग्नेंट फीमेल टेकिंग लिथियम प्लस risk of, I'm writing with a colored pen, WPW syndrome, WPW syndrome is Wolff Parkinson White syndrome, it can cause PSVT। तो अब आपका डायग्नोसिस क्या है, यू नो द आंसर, द डायग्नोसिस इज एब्स्टीन्स अनोमली, एब्स्टीन्स अनोमली। और एब्स्टीन्स अनोमली में व्हाट इज द शेप ऑफ द हार्ट, बॉक्स शेप्ड हार्ट विल बी सी, बॉक्स शेप्ड हार्ट विल बी सी। एटलीस्ट देखो, ये ये चीजें पता है आपको, यू नो इट ऑलरेडी, और मैंने क्यों लिखा है, कॉमन चीजों में अब हमें हाई एक्यूरेसी चीज चाहिए, एंड इफ यू हैव every single word I am writing, I'm very meticulous with that। If any of the word is not known to you, just add them to your notes and revise it, you never know, maybe that word is the only thing which is asked in the exam, these are all very characteristic things। So if I zoom out, this revision of this page will take what, maybe 5 minutes, but this is important, at least diagnosis गलत नहीं होना चाहिए, if it is a statement based question you get it wrong, acceptable, diagnosis should not go wrong, and most of the questions are actually diagnosis based only, at least in pediatrics। It is only in surgery these days you have questions asking you, this is done, this was diagnosed, what is the next step in management, the surgery was done, what is the next step, generally these next step kind of questions are not very frequently asked in the other subjects। Let us go further. Question number 13. Question number 13. So a 4-year-old boy, एक घंटा हुआ है. My target is that the session should not go beyond 12:10 or 12:15. So we are well on track for that. Question number 13. 4-year-old boy presents with progressive facial puffiness, periorbital edema, and reduced urine output for 5 days. Pitting edema is there over both ankles and blood pressure is 90/60. Urine analysis, this, serum analysis, cholesterol is markedly. What is the most likely diagnosis? You have, whenever you have a presentation like this, keep it in your mind. What is the question saying? There is a child presenting with periorbital edema. Whenever there is periorbital edema, it is likely to be a glomerular cause of edema. So there is a glomerular disease. If the question says it has 3 plus or 4 plus urine protein, it has to be nephrotic syndrome. And if the question says 1 plus or 2 plus urine protein with hematuria, your answer is going to be acute nephritic syndrome. Acute nephritic syndrome, right? So this is nephrotic. Particularly, nephrotic will have uh, hypoalbuminemia, low serum albumin, and increased cholesterol levels. So in this patient, there is 3 plus protein, no hematuria, serum albumin is low, cholesterol is markedly elevated. So diagnosis is nephrotic, definitely. Now, which is the most common type of nephrotic in age 2 to 8 years, where there is no hematuria? It is idiopathic. And when you do biopsy, what you will find? Nothing you will find. We call it as minimal change disease, MCD. So this is minimal change nephrotic syndrome. That is your answer. If it is acute nephritic, then your possibilities can be IgA nephropathy and PSGN. Remember, IgA nephropathy occurs 1 to 5 days after precipitated by infection. PSGN occurs 1 to 3 weeks after any respiratory infection. After infection. IgA nephropathy has normal serum C3 level. PSGN has low serum C3 levels. इससे distinguish करते हैं. Another common mistake people make. सर IgA nephropathy है, IgA बड़ा होगा? नहीं बड़ा होगा. Nelson कहता है, Nelson says, I'll say in English, sorry. Nelson says IgA is elevated only 15% patients of IgA nephropathy. You understand? So what is the diagnostic clue? Biopsy is needed. When you do biopsy, you find mesangial IgA deposits in the patient. So this is the clue, and the answer to this question is very, very clear. Let's go further. Question number 14. Now, another INI set question, and the topic is primary immunodeficiency, and many of you do not read it properly. So we will do a very short but crisp review of the topic. 9-month-old boy presents with recurrent otitis media, pneumonia, chronic diarrhea, frequent bacterial infections in 6 months of age. Examination revealed. अब keywords देखो. Tonsil नहीं है. Okay. Lymph nodes are very small. So lymphatic tissue is hypoplastic. Immunoglobulin, all the immunoglobulins are reduced. IgG, IgA, IgM. And there is absent CD19 plus B cell. What it means is that there are no B cells producing antibodies. No antibody means A gamma globulinemia. And it is a boy presenting in first year, Bruton X-linked A gamma globulinemia. Okay, let us understand. Let's make a flow chart here. Primary immunodeficiency is a very, very complicated topic. Tomorrow, the day you crack your FMG and you start to read something, among the things that you will be reading in details, if you are a serious aspirant for not just NEET PG but INI set, is this topic. But अभी सिर्फ एक flow chart करेंगे so that your expected easy question and all the NEET PG and INI set questions are you're able to solve, right? So just give 5 minutes. This some of the things you would have heard already. Child with There is a child with suspected immunodeficiency. When do you say is suspected immunodeficiency? Because he will have recurrent infections. तो क्या करोगे? There can be three possibilities. First possibility, it can be acquired immunodeficiency. Acquired can be either due to HIV or it can be due to protein energy malnutrition or it can be due to steroids. You all know that steroids can cause acquired immunodeficiency. Okay. And second immunodeficiency is primary immunodeficiency. Primary is something the child is born with. So that is primary immunodeficiency. प्राइमरी इम्यूनोडेफिशिएंसी फर्दर दो तरह की हो सकती है, तीन तरह की हो सकती है, इनफैक्ट कई तरह की हो सकती है, बट वी विल स्टे विद इन लिमिट्स. सो प्राइमरी इम्यूनोडेफिशिएंसी कैन बी कंबाइंड, it can be combined B and T cell immunodeficiency. It involves the humoral system and the cell mediated system. फिर हो सकती है predominantly B cell mediated. थर्ड हो सकती है predominantly T cell mediated. And fourth variety will be phagocytic defect. Phagocyte में problem है, phagocyte defect, right? Not B and T cell, but neutrophil, lymphocyte, their movement has having problem. Combined B and T cell का example है SCD. What is SCD? Subacute, severe combined immunodeficiency. Severe combined immunodeficiency. In these patients, all live vaccines are contraindicated. All live vaccines are contraindicated. ये INI सेट का नवंबर मई 25 का MCQ है. So all live vaccines are contraindicated, right? B and T cell, both are not there. Then predominantly B cell mediated, you have X-linked B cell, predominantly B cell is the word, X-linked A gamma globulinemia. X-linked A gamma globulinemia. इसमें क्या होगा? These patients will have, right in bracket, all immunoglobulins are absent. CD19 B cells are absent. Tonsils are absent. But T cell function will be relatively preserved. और इनमें रिकरेंट इन्फेक्शंस होंगी, राइट, पर्टिकुलरली कैप्सुलेटेड बैक्टीरिया से. तो इसके अंदर जीन होता है, एक्स लिंक्ड है, तो इट विल बी सीन इन बॉयज. एंड इसके अंदर जीन होता है बीटीके जीन. बीटीके जीन, तो इसका दूसरा नाम क्या है? ब्रूटन्स एक्स लिंक्ड ए गामा ग्लोबुलिन. बीटीके जीन है तो ब्रूटन नाम देते हैं. ब्रूटन टायरोसिन काइनेज इज द जीन विच इज इन्वॉल्वड हियर. सेकंड, ये पहली पॉसिबिलिटी. दूसरी पॉसिबिलिटी, एग्जामिनर विल हैव raised IgM but low IgG and low IgD. IgM बढ़ा हुआ है लेकिन IgG और IgD घटा हुआ है. अगर ये क्लू हो तो योर डायग्नोसिस इज गोइंग टू बी हाइपर IgM सिंड्रोम. हाइपर, आई एम ट्राइंग नॉट टू लुक एट द कमेंट सेक्शन. मुझे नहीं पता व्हाट इज हैपनिंग देयर, बट आई जस्ट वांट टू राइट in a way that nothing goes out. I don't have a script in front of me, so only based upon PYQs I'm writing it here. Third, if examiner says only IgA is deficient and there is celiac disease associated with it, you all know what is celiac disease, gluten sensitive enteropathy, तो आपका आंसर होगा selective IgA deficiency. और अगर आपके पेशेंट के अंदर हो जियार्डिया इन्फेक्शन, रिकरेंट जियार्डिया इन्फेक्शन एंड माइल्ड इम्यूनोडेफिशिएंसी, तो होगा कंबाइंड वेरिएबल इम्यूनोडेफिशिएंसी, CVID. कंबाइंड वेरिएबल, ये ऊपर लिखा भी है, ए वाला ऑप्शन. सो कंबाइंड वेरिएबल इम्यूनोडेफिशिएंसी. ओके. प्रीडोमिनेंटली टी सेल, डाइजॉर्ज सिंड्रोम. यू रिमेंबर डाइजॉर्ज सिंड्रोम? Catch 22. Thymus is missing, so they will have Dijot syndrome. Okay. And phagocyte defect, example, LAD. What is LAD? Leukocyte adhesion defect. Leukocyte adhesion defect. और इन पेशेंट्स के अंदर क्लू क्या होता है? The clue will be delayed fall of umbilical cord. Delayed fall of umbilical cord. I'm putting a small Q here, Q here, Q here, and Q here. Now you see the number of questions which have been asked in NEET PG and INI. Should you be reading in details about it? Can you leave it? You can leave it. You can leave it, right? But close to the exam, एक टॉपिक जिससे बहुत बार आईएनआई सेट और नीट पीजी में क्वेश्चन आया है, एंड इट इज जनरली नॉट टॉट बिकॉज इट हैज नेवर बीन आस्क्ड डायरेक्टली, इन अ क्लिनिकल फॉर्मेट इन एफएमजी. इट इज ऑलवेज बेटर दैट एटलीस्ट कुछ पढ़ के जाओ. नाउ यू विल से कि सर याद रहेगा ये? You will have a fighting chance. Somebody is going into the exam without even having an idea about it. You have at least read this flow chart. You will, at least you can rule out the option. You have a much better fighting chance. Negative marking is not there, right? So I'm just zooming it out a bit. So this is what you can see in the photo, right? So I hope it is visible to all of you. You can later on pause it. You can later on write it down. राइट, ये वाला फोटो मैं शेयर करता हूँ. ये वाला फोटो अच्छा है, मतलब मुझे अच्छा लग रहा है बना के भी. सो दिस फोटो पर्टिकुलरली आई विल शेयर इन माय टेलीग्राम ग्रुप ऑल्सो, राइट. ये वाला फोटो, तो इसको समझ लो एक बार. नाउ लुक एट द ऑप्शन. ऑब्वियसली इस क्वेश्चन में क्या है? Absent tonsil, small lymph node, absent all immunoglobulins are absent CD19 B cell and X-linked recessive in boys. So what is the answer? Bruton's X-linked A gamma globulin. Selective IgA deficiency नहीं हो सकता because that will have what? That will have only IgA deficient and other antibodies relatively preserved and celiac disease will be there. Hyper IgM syndrome, IgM high, others are low. So this is not there. CVID, GRDS is bolega and other immunodeficiencies will be relatively mild. The levels will be low, but they will not be absent and CD19 B cell will not be absent. Okay, so this is the answer. Let's go further. डाई जॉर्ज समझा दीजिए. करिश लामा, डाई जॉर्ज सिंड्रोम क्या है? TBX5 जीन होता है. Listen to me carefully. You can listen to it again, the video. TBX5 gene is found on long arm of chromosome 22. There are micro deletions happening in that. So it is also called as 22q deletion syndrome. When micro deletions happen, third pharyngeal pouch and fourth pharyngeal pouch do not form. Third pharyngeal pouch forms thymus and third and fourth Milky they form parathyroid gland. So patient who is having TBX5 gene mutation due to deletion in 22q11.2 area, they will have catch-22. What is catch-22? Congenital heart disease will be there, abnormal face will be there. T means thymic absence and thymus is absent, so T cell will not form. B cell will be normal. C will be cleft palate there and H is hypocalcemia. This is how they come to attention. When these kids will be born, parents will look at the child and they will be like, kid's face is not resembling father or mother. Then plus the child will have repeated episodes of hypocalcemia. Then that is the time during which the suspicion arises. And when echo is done, you will find heart disease is inside. So this is, and 22 is the chromosome number, right? This is the maximum we can discuss here. Let's go further. Question number 15. Question number 15. A 4-year-old previously healthy girl presents with sudden onset of petechiae, bruising over the limbs and gum bleeding for 2 days following a upper respiratory infection. She is afebrile, no hepatosplenomegaly, no lymphadenopathy. Platelet count is 18,000 with normal hemoglobin leukocyte count. What is the likely diagnosis? Isolated fall in platelet triggered by respiratory infection, but no hepatosplenomegaly, no lymphadenopathy. This is acute ITP. This is acute ITP. Remember, if there is low platelet count, if there is low platelet count, remember four things you have to remember. Low platelet count in a child. If examiner says triggered by, ये जो मैं फ्लोचार्ट के फॉर्म में कर रहा हूं, the reason for this is I am summarizing everything together and trying to cover multiple topics in one question. Okay. So most of these things, I assume that you have at least read or heard about them. So if low platelet count, that is thrombocytopenia, low platelet count is called as thrombocytopenia. If it is triggered by viral infection, it is having no hepatosplenomegaly, no lymphadenopathy. HSM is hepatosplenomegaly, LAP is lymphadenopathy. They are not there. Bone marrow study, if you do, you will find megakaryocyte hyperplasia. ये क्लूज है. ये वाला क्लू इस बार आयनाइसेट और नीट पीजी दोनों में आया. बोन मैरो शोइंग व्हाट? मेगाकैरियोसाइट हाइपरप्लेजिया. And size of the platelets is normal. Size of the platelet is normal to increased. तो आपका likely diagnosis क्या है? Acute ITP. Acute ITP. Children do not get chronic ITP, they get only acute ITP. Okay, self-limited होता है. If examiner says there is decreased platelet count with hepatosplenomegaly present, lymphadenopathy present, bone pain present, bone pains present, weight loss present, and anemia, pancytopenia is present. Pancytopenia, not just platelet, but WBC and pancytopenia is present, or increased very high WBC count, you will think of acute leukemia in the patient. Acute leukemia will be thought of. ALL is more common than AML. Third, if examiner says there is pancytopenia, pancytopenia, but no bone pains and no hepatosplenomegaly, you will think of third possibility, aplastic anemia. Aplastic anemia. And fourth, if examiner says small platelets, thrombocytopenia with small platelets, they will write MPV, mean platelet volume to be low, plus recurrent infection along with rash due to eczema, ectopic dermatitis. Your diagnosis will be Wiskott-Aldrich syndrome, WASP gene mutation. This is the differential diagnosis. Are questions asked on these? Yes, questions are asked on all four of them. It's just that we do not read them in details. An acute ITP में याद कर लो, treatment is always conservative. And if platelet count is less than 20,000 or severe bleeding is happening, then you treat the patient. And when you treat, you will give IVIG followed by steroids. This flowchart again covers at least 4 to 5 MCQs, including some recent questions of all the exams, FMGE, NEET PG, INSET as well. So please add it. Anumita Bernard-Soulier syndrome is a platelet function defect. It is not a platelet thrombocytopenia defect. And second, Bernard-Soulier syndrome, I have never seen. I have not met anyone who has ever seen in pediatrics. Adults, it happens. It's not common in children, although these are genetic conditions, but they do not come to attention. They are not very common. They are very, very rare. Here, I'm only discussing the common things. उनको कहते हैं Bernard Soulier, Glanzmann thrombocythemia. They are considered platelet function disorder. We do not read about them in pediatrics. We read them in medicine. Okay, let's go further. Let's go further. Question number 16. We're on to the last 5 questions. This is easy one. You give me the answer. I'm looking at the chat box. Look and give me the answer. 2 week exclusively breastfed infant, persistent vomiting, jaundice, hepatomegaly, failure to thrive, cataract. ये तो PYQ है. This is PYQ of FMG. Positive urine reducing substances. What is the most likely diagnosis? You tell me. What is the answer to this question? Answer to this question. Yes, absolutely right. Classic galactosemia, that is GALT deficiency, is the likely possibility. Okay, so remember that whenever there is classic galactosemia or GALT deficiency, galactitol getting increased is responsible for oil drop cataract, whereas rise in galactose 1 phosphate is responsible for hepatotoxicity. Hepatotoxicity. And raised galactose in the blood itself, is responsible for E. coli sepsis. I'm writing like this. This is important. People tend to get confused. These are the culprits. Gunahgar. If you can't read Hindi, I'm just pulling a leg. I'm just randomly doing things. It's midnight, I'm tired. So I'm just, doing random things. I can do that. I am not supposed to sit in the exam. You people are not supposed to do random things. So culprits means I'm leaving clues for your brain, basically. When you do random things, people tend to remember the things better. Two, three type of questions can be asked. They can make the diagnosis and they can ask you, oil drop cataract is due to which? Galactitol. Hepatotoxicity is due to which? Galactose 1-phosphate. E. coli sepsis is due to which? Not some metabolite. Galactose itself favors the growth of E. coli in the blood. Okay, so you know the answer. Let's go further. Question number 17. Question number 17. It's an easy one, but still you need to read. Read and tell me the answer. A 2-month-old infant presents with mother reports difficulty in breastfeeding, considering switching to cow's milk. She wants to know what are the differences between cows and breast milk. They are asking you to identify which is the most significant compositional difference. Hello, Narayan Vaishnav. Hi. So options, look at these are the options. Tell me the answer. Breast milk has higher lactose. Let's go one by one. Okay. Breast milk has higher lactose content than cow's milk. True. Cow's milk has higher IgA content than breast milk. False. IgA is found in breast milk. Cow's milk has lower protein content than breast milk. False. Cow's milk has higher protein. Breast milk contains significantly more sodium than cow's milk. False. Breast milk has appropriate sodium. High sodium, right in bracket. High sodium, high calcium, high phosphorus are features of animal milk, not human milk. So what is the correct answer? A is your correct answer. A is your correct answer. It's an easy one. Overthink नहीं करना exam में. आगे चलते हैं. Let's go further. Question number 18. Last three questions. I know you're tired. I'm tired, but let's finish the job. Question number 18. 10-day-old neonate. Prolonged jaundice, poor feeding, constipation, lethargy, large anterior fontanelle, macroglossia, सब कुछ दे दिया. What is the diagnosis? Congenital hypothyroidism. Congenital hypothyroidism. What you will do? Serum screening. कैसे करोगे screening? How would you do screening? Serum TSH levels. When do you check them? 72 hours of birth. कैसे करोगे? Heel pad prick. Heel pad prick. Cut off क्या है? If value is more than 20 milli international unit per ml, positive test. Do TFT. Do ultrasound. Do iodine 123 scan. And start levothyroxine. What is the dose of levothyroxine? FMG examiner for some reason are obsessed with levothyroxine doses. They ask not only in pediatrics, if you read medicine, in medicine also they ask less than 50-year-old person, how would you increase? पहले इतना देंगे, फिर इतना देंगे, फिर इतना देंगे. More than 60-year-old person, how you will increase? So please go through, you never know, but at least go through the levothyroxine dose regimes. Not many, but pediatric, though I have told you, medicine I'm not telling you here. So you are supposed to go through it, right? At least the PYQ, go through that. Just when you will be tomorrow preparing for INI set, I know you will be preparing. I'm assuming you will be preparing in 2026 second half. So when you will be preparing for INI set, you will find INI set people are obsessed with the neonates. Neonatology, 4-5 questions they ask from neonatology. They're also obsessed with lysosomal storage disorder, Gaucher, Kucher. You have to go into the depths of that. Fortunately, FMG people still don't ask the fine details of these things, but they have some typical areas, and this is again one typical area from question where questions are being asked. Brief review of Shahid Ahmed, congenital adrenal hyperplasia, but bhai, that takes minimum 15-20 minutes. We do not have the time for that. I have been strictly told by the organizers to keep it 1.5 hour only. It's already 1.5 hour. So let's try to finish off. But you can always reach out to me. I'll try to be in touch again with all of you. मिक्स एडिमेटस का डीडी यार ये तो मेडिसिन नहीं पढ़ाऊंगा मैं आई एम नॉट टीचिंग मेडिसिन प्लीज वो मेडिसिन का पार्ट है दिस पीडियाट्रिक्स आई विल नॉट टीच मेडिसिन क्वेश्चन नंबर 19 5-year-old healthy child look at the key feature high grade fever sore throat no history of barking cough stridor is present high grade fever sore throat difficulty in swallowing and look at this sign swollen epiglottis forming a thumb sign. So what is the likely diagnosis? This is acute epiglottitis. Acute epiglottitis. एपिग्लोटाइटिस. ओके. एंड क्या जूम आउट कर सकते हो? लो भाई, जूम आउट कर दिए. जूम आउट कर दिए. आशीष कुमार व्यास, आई हैव डन द जूम आउट. राइट. सो व्हाट इज द लाइकली डायग्नोसिस? एक्यूट एपिग्लोटाइटिस. और क्या करेंगे एक्यूट एपिग्लोटाइटिस में? You have to first secure the airway. That is the most important thing to do. So secure airway with controlled intubation in the operating room. Why not others? Outpatient setting में you try to be adventurous, complete obstruction can happen. Nebulized epinephrine is indicated in severe croup, not in epiglottitis. An oral antibiotic has no role. You start with IV antibiotic, and once the response comes, then you go to oral antibiotic for completion of the therapy. But the first sign is always securing the airway, and so B is your correct answer. Question number 20. ये है अगेन आई नहीं सेट क्वेश्चन. ये गलत हुआ होगा बहुत सारे लोगों का, आई नो. मैनी ऑफ यू, सो दोज हु आर थिंकिंग कि सर मेरा 16 आया, 15 आया स्कोर, वी हैव डन ग्रेट. There was one question on primary immunodeficiency, which generally is not a FMG topic, but we included because we wanted to push the boundary, and this is a NEET PG INI topic. Second was surfactant deficiency, neonatal PAP question, and third is this question. And another question might have gone wrong somewhere. So if you have got 15 to 16 while giving the exam, good. Don't be too happy, but good. Okay, be satisfied at least. Question number 20. Term neonate delivered by vacuum assisted vaginal delivery develops a fluctuant scalp swelling within 4 hours of birth. Swelling is boggy, crosses suture lines, and has progressively increased in size. Infant is pale and tachycardic, hematocrit is low. Remember, cephalohematoma and caput succedaneum do not cause shock. If shock has happened, subgaleal hematoma should be thought of. Subgaleal hemorrhage or hematoma should be thought of. Right? Let us understand. Let us understand. Look at the location first of all. I'm zooming out. The first photograph is showing you caput succedaneum. It is soft tissue swelling. There is no blood. So they have shown with a blue color thing below the scalp. So this is caput succedaneum. This is the line, suture line. So it is crossing the suture line. Can you see it is crossing the suture line? Because it is diffuse. It's like a cap. Look at the third one, cephalohematoma. It is below the periosteum, subperiosteal bleed. This pink color line, this purple line is this periosteum. So below periosteum, because it is below periosteum, this is not crossing the suture line. So it is restricted and it is localized, and amount is less because periosteum limits. It has pressure effect, does not allow the blood to ooze. Subgaleal hematoma is superficial and it is above periosteum. And because it is periosteum above and bleeding starts, the bleeding cannot be splinted by the periosteum. And so it continues to go and leak into the spaces. And this can enlarge progressively and can lead to shock in the patient. Visible bleeding nahi hoga, but patient will be bleeding on the inside. The only good thing about subgaleal hematoma is it is relatively rare. अब question में पता कैसे करना है? How to identify if you're having a bad day and you get the question wrong? Let us understand. Let me make again flowchart. Flowchart से खत्म करेंगे. आज बहुत flowchart बनाए मैंने. So neonate with head swelling after birth. Neonate with head swelling after birth. Okay. First possibility, diffuse, soft, asymptomatic. No symptoms are there. Asymptomatic. Crosses suture lines. Crosses suture lines. You will think of caput succedaneum. Localized, firm, asymptomatic, does not cross suture line, does not cross suture lines. What is the answer? Cephalohematoma, also called as cephalohematoma. Pronunciation doesn't matter. Correct answer matters. And third, localized or diffuse. It can be localized or diffuse. Bahar se. Inside though it is diffuse only, but it can be either localized or diffuse. But look at the words. Boggy swelling. Boggy word is important. Boggy word use करता है examiner. Symptomatic, what are the symptoms? Patient will have shock. That is low BP will be there and poor pulses will be there. Symptomatic in the form of shock and crosses the suture lines. Crosses the suture lines. This will be subgaleal hematoma. Subgaleal hematoma. कैपुट सेकेडेनियम का रिस्क फैक्टर क्या है? इट अकर्स इन नॉर्मल वजाइनल डिलीवरी. कैन अकर इन नॉर्मल वजाइनल डिलीवरी. This is common in instrument whenever you are using instrumentation. For example, you are using forceps, and this is seen when ventouse or vacuum are used. They are the risk factors. You know, the vacuum delivery. What is the treatment? This self resolves in 48 to 72 hours. This self resolves in 3 to 6 months. This will not resolve. Life threatening. Give blood transfusion and plan neurosurgery. Call the neurosurgeon. Surgeon will be needed in these patients. Most common, second most common, rare. इसके beyond मत पढ़ना, काफी है. This is more than enough. But at least use it, read it 2 times at least, because whatever you read once, you will not be able to recall in the exam. So, dear friends, we are done with it. I'm proud of you. You are sitting at 12:22 a.m. and listening to me. I hope all of you are doing good. Of late, let me tell you, a lot of you have sent messages to me, but I have been too engrossed. I had commitments to fulfill regarding offline classes for DocTutorials, which I'm taking for NEET PG batches. Plus, I had some personal health issues at my home. With God's grace, things are settling down now. And plus, things sometimes get overwhelming. So I have not responded to many of your messages. But at the same time, since things are falling in place and exams are approaching, me, your favorite teachers at DocTutorials, Rajiv Dhawan sir and all Khalil sir and everybody, we will try our best to be available for all of you. And if you have any doubts related to my subject, related to preparation in general, please reach out. But end of the day, remember, whatever workbooks you have made, whatever things you have read, they along with PYQ, if you read, that's good enough. Don't try to read anything, out of this world at this last moment. If there is a particular weak subject, you can definitely focus on that. And too many rapid revisions and too many, sessions, too many QRPs. Last minute, if you do, make sure to do it 2 times. Because if you read it only once, even if it is gold, you will not be able to remember it. So this is something you need to remember. And thank you so much. The days are hectic, but work has to be done. You have a work to do. I have a work to do. This is my job. So I'm doing it. You do your job, cracking the exam, and we all will wait for your bow. These are the Instagram links and the Telegram link. File, I'll say again, this will be shared with the DocTutorials team. So file rights are theirs because I'm checking on their channel. It's a legal thing. I cannot share with all of you. But that snapshot of primary immunodeficiency that I will share in my group. So you can, just have a look at that. So thank you so much. Keep reading and don't miss the other sessions and DocTutorials that we are bringing for all of you. Thank you so much.